Good. It is 2 o'clock, so welcome to today's meeting of the Norfolk and Waveney NHS Integrated Care Board. I'm Patricia Hewitt, I chair the board and I'll be chairing the meeting today. This meeting isn't being broadcast live, but it is being recorded and will be available to watch on our website after the meeting. Warm welcome to any colleague or all colleagues and members of the public who've joined the meeting to watch this live. But we'd all be very grateful if members of the public observing the meeting could turn off your microphone and your camera during the meeting. There is an opportunity for members of the public watching the meeting live to ask questions about items on the agenda or ask for clarification if they're uncertain of anything that's discussed. That can be done by raising your hand in the slot at the end of the meeting for questions, or if I invite them earlier on. But members of the public can also raise questions by email during the meeting, and the email is nwicb.contactus@nhs.net. If the question relates to an agenda item, we'll read it out at the end of the meeting, but we have had notice in advance of a question, and so we'll answer that question during the meeting. But questions that are submitted late that we're not able to answer on the spot, we will prepare a response in writing. It will go to the person asking the question within 7 days of this meeting, and we'll also put the answer on the website. I do just need to stress, please don't use the chat function during this meeting. Both observers and board members, please don't use it, because it's really important that any comment that is made during the meeting is formally recorded by the minute taker. So any comments or questions should be spoken, or, as I said, by observers sent by email. The board meeting is a meeting of the Integrated Care Board held in public. It's not a public meeting as such, and so any questions that don't relate to agenda items will simply will not be read out in the meeting. They'll be answered and displayed on the website in the way I've just described. And finally, because the meeting's recorded and it's in the public domain, I would ask everybody, just don't share any personal information or information relating to somebody else if you're raising a question or asking for clarification about an item on the agenda. So let me just add to, in terms of welcome and introductions, I do particularly want to recognise and thank one of our partner members, Stephen Coleman. Stephen has been the partner member for mental health and community health from the beginning of our, or nearly from the beginning, forgive me, of our statutory integrated care board, but very sadly from our point of view is leaving Norfolk and Waveney in order to take up a rather exciting new position much closer to his home in the Midlands. So Stephen, I just want, on behalf of the board, to thank you for everything that you have done as a member of this board, and of course in your role as Chief Executive of NCHC, our community trust for people in Norfolk and Waveney. And thank you very much indeed for your service as a board member. We will also be welcoming we will be welcoming a new board member who I hope will be joining us as a guest at some point this. Oh, Stuart, I can see you there. Sorry, you're not coming up in the right place in my list. Let me just welcome Stuart Keeble as our new partner member designate from local government, nominated by Suffolk County Council and Norfolk County Council, and replacing Sue Cook on this board. Stuart, I think we have a few formalities to complete before you formally become a member of the board, but we all look forward very much to working with you and Thank you for joining us this afternoon. Chris, do we have apologies for absence for today?
We don't have any apologies for absence today.
Wonderful. That is the benefit, I think, of an online meeting, which has other lesser advantages. Right, minutes from the previous meeting. Is everybody happy with the minutes? They've been circulated in draft. Thank you very much. We can approve those. Declarations of interest, they're all, of course, recorded and published on our website. Just draw attention to them if you think that's appropriate during the meeting. Next item is the chair's action log. There, I haven't had to take any actions as chair in that formal sense since the last meeting, but the wider action log, Karen, I think you have an update for us on that.
Thank you, Chair. Yes, just to say that action 11 and 12 is completed and that those items are both on the agenda today. Action 13 is also completed and the answer to that can be found on our website under the July board documents. And then with regard to action 14, we just want to clarify the log. The learning from deaths paper is on the agenda for today, but the item was referring to an end of life care future agenda item, just to make that clear, and that is on the forward plan for the board for March. It will come to the board following review through the committee stages of the ICB. So that's just a correction to the log.
Thank you very much indeed, Karen, and otherwise those other items are closed. Good. Thank you. So we now come to Tracy's and my report, Chair and Chief Executive report. And before I hand over to Tracy, I just really want to reflect on the fact that this is an exceptionally challenging time, not simply for everybody working within our organisation, within the Integrated Care Board, but across the whole of the NHS and amongst all our partners in local government, in social care providers, in the voluntary sector, and so on. And I hope what everyone will hear during this meeting is really the extraordinary amount of work that is being done and the very real progress that is being made, even in these exceptionally difficult conditions. But for our own staff in particular, the restructuring and the very large cut in our running costs and in our overall headcount that we are having to make as part of a reorganisation to make us fit for the future, that is imposing considerable stress and anxiety upon our staff. So we all need to bear that in mind. And I just want to thank everybody working within the wider system, but especially our own staff in the Integrated Care Board for the great professionalism with which you are all continuing to work, even in these very difficult circumstances. So let me hand over to Tracy to highlight key points from our report.
Thank you, Patricia. It is incredibly busy, but I'm going to start with a pause. And that pause is to reflect on our one-year annual return from NHS England, our performance review, if you like, on our first year of formally being an Integrated Care Board, because it was really so positive. We know we're 1 year in, we haven't solved every issue in Norfolk and Waveney, far from it. But what has been reflected on is the energy and the passion within all of our health and social care staff, the tenacity and how hard everybody's working, and the plans that we've put in place over so many challenging areas to really move health and social care forward for the benefit of all our residents. So I'd like to pause, reflect on that. I'm very pleased actually about where we are 1 year on, and to say that it is to the credit of everybody working in health and social care in whatever part of our system, from the voluntary sector, through local authorities, through private companies, social care, everybody involved in the NHS. Everybody is working so hard through such difficult times. So to get a report like this, I am incredibly proud. Just to talk through some of those areas that are challenging us at the moment, we are in the middle of a two-phased period of industrial action at the moment, which represents 4 days of essentially Christmas Day cover, and that's both consultants and junior doctors on strike at the same time. We are dealing with the 2 periods as a singular incident. We've put lots of planning in place. There's a huge amount of work going on across the region to support colleagues and of course nationally as well. But we can't overlook the fact that everybody is getting really tired now, actually, and the impact that this is having on our patients, on our elective waiting lists, on families and carers as well, on really every part of our system, as well as the staff who are trying so hard to keep the system safe. We don't know when this will end. We don't know how this will end, but we do need to really raise the point just how much energy this is taking. And one particular group of staff that I'd really like to mention, actually, because they're often forgotten, are the admin staff who are working predominantly within our hospitals, but also in our wider system, who are having to ring patients up and they're having to rebook those essential operations. And they're dealing, of course, with families, with patients who are incredibly worried, feeling very unwell, desperate for their treatment. Those people are really almost the unsung heroes, I think, of the industrial action, and they have incredibly difficult days replanning everything. So I really would like to just take this opportunity to say thank you, especially to them. We are, as Patricia mentioned. Oh, has somebody come off mute?
Okay, could Alice?
I've just muted everybody. Hopefully that will work. Sorry, Patricia, I muted you as well then. Thank you. So just in terms of our consultation as an integrated care board, we are going through a consultation at the moment to reduce our running costs by 30%. This is quite well known. We've talked about this publicly. This is something that all ICBs across the country are going through at the moment. We are running also a voluntary redundancy scheme at the same time to try and minimise the impact on our staff. We are very much in line with the national recommendations as well, so waiting for a timetable on the voluntary redundancy to come out to be able to confirm when all of this will be complete. But we are certainly hoping that by the start of the financial year next year on the 1st of April, we will have our structure in place, we will have people recruited to the new roles, and we will be able to move forward in our new structure. Of course, remembering this is incredibly difficult for staff at the moment, but it does mean that we are able to reshape our organisation to match the joint forward plan and the new structure of the integrated care board and the system as well. So we are really creating something bottom up that is going to serve our patients and communities. That is the intention. But of course, we can't overlook the impact that that is having on staff at the moment, staff and their families. This is a really tough period for everyone to be going through. We're also very much leaning in, as we've always said as a board, to our financial plan this year. It's another very tough financial plan, and we are determined to break even. As an integrated care board, that's meant making tens of millions of pounds worth of savings, which we have tried to do by looking at alternative ways of doing things, making sure we minimise waste in our system. We absolutely maximise all the efficiencies that we can make and make very best use of absolutely every pound that we spend, because if we overspend, that means money being taken away from care elsewhere. So we have 100% of our efficiencies identified now as a system. Everyone's worked incredibly hard to make sure that we can run to a budget. Of course, we still have 6 months left of the financial year to run, and there are all kinds of risks, but I'm really proud of the way that not only the finance team, but everybody is really, really working hard to make sure that we use our money as well as we possibly can through a very, very challenging period at the moment. So it's another thing really to thank everyone for. And then I'll speed up a little bit because I'm taking a lot of time. We've got a lot on the agenda. We're working really hard on the new hospital programme at the moment. We are having 2 new hospitals in Norfolk and Waveney, the James Paget and the Queen Elizabeth. We're making sure that we design those from a system perspective, and we're looking forward to 50 years of those hospitals and making sure they serve our populations. We're putting plans in place for the winter, which will be upon us any time. And we know that we're going to have a challenged winter with flu and COVID and everything we saw last year. But plans, relationships and ways of working are much improved. So I'm hoping that we're going to have much better performance for our residents. And we are about to launch our short-term plan for dentistry as well, having picked that up on the 1st of April. absolutely recognise the challenges that many of our residents have had accessing dentistry services. We can't solve it overnight, but we are working very, very closely with dentists, also community pharmacy as well, which came over on the 1st of April to improve services. I'm going to pause there and take any questions. Thank you.
Great. Tracy, thank you very much indeed. Questions or comments from board members? Cathy, and what would be helpful if each of our board members just explain who you are, please, at the first time you contribute.
Okay, thanks. I'm Cathy Armour. I'm a non-executive member of the ICB. So my question is not something you've mentioned actually, but it's about Stephen's replacement. And this is the second time now in this region that we've had a person who's already got a very big job. And I just wondered, is this a deliberate strategy now to appoint across, two hospitals or even 3? Or is there a lack of chief executive development or is there a dearth of good chief execs in the waiting? What's going on? Why is there a need for appointing people who've already got very big, busy jobs?
Thanks, Cathy. I think the important thing to recognise that with both the Norfolk and Norwich and NCH&C, these are interim appointments.
Yeah.
So we wanted to get somebody in place very quickly, especially to allow Stephen to go off and do his new job as well. So this is to make sure that we don't have a gap when we're going out to recruitment. So it's actually quite efficient to get somebody in who's already got a job quite locally. And in the 2 cases of the 2 individuals that you're talking about, they already work with us. They know our patch. They've been involved with Norfolk and Waveney. So it's actually quite a good solution while we go out and do that full recruitment process.
Yeah, and I would just add to that, partly, I suppose, because the NHS collectively is such a large organisation, it is remarkably common for experienced senior chief executives of an individual trust also to have a role in a national role or a second role in a role in another organisation. And in the case of Matthew Wynne, of course, he's been leading really on community service development at the centre in NHS England, as well as being chief executive of CCS. So I think he's widely regarded as quite a catch for us in his interim roles. So I think we should be proud of that. Although I think your wider point about talent development across the NHS is also really important, though we can play our part, but we're not obviously responsible for all of that. Any other questions or comments to Tracy? Right, well, thank you very much. We can, as a board, just accept and note that report. And that brings us to our annual report and accounts. Tracy, I think you're going to introduce this.
Thank you very much, Patricia. This is the one time that I'm very pleased to be introducing a very dull report. So these are, of course, the ICB annual report and the CCG annual reports, and the dull reports I'm talking about, of course, are the auditor reports. The auditors have found that both of these sets of accounts, they're very interesting to read in themselves, have no issues in them whatsoever, are fair and full account of our reports, and they have been submitted to NHS England already in terms of the timescale, but we're now presenting them back to the board. Stephen, was there anything that you wanted to pull out in particular?
Thanks, Tracy. So I'm Stephen Corse, Executive Director of Finance for the ICB. There's 2 reports, strangely, this year, because we had the CCG in existence until the 30th of June before the ICB started on the 1st of July. So we had 2 audits this year, hence why there are 2 reports which are in the papers today. As Tracy says, there was no issues to report by exception. We had good reports back on value for money. We had unqualified opinions and true and fair statements on our finances. So a good position on both reports for us to be in. Our annual government statement was consistent with the auditor's understanding of our organisation, which is also important to note. There were 2 recommendations which were the same recommendation in each report, which is something we've taken away management decision is to implement the recommendation. Auditors found that some of our contracts, particularly the smaller variations to contracts, weren't always covered by a contract in a timely way. So something we'll take away and correct for next year's audit.
Thank you very much indeed, Stephen. Any questions or comments? David.
Thanks, Patricia. I'm David Holt, one of the non-execs. I chair Audit Committee. Really just to say that this is a very clean set of reports, and we've talked about, I guess, the stresses and strains that some of the other members of our team have been through, but for a finance team to produce 2 sets of accounts in 1 year through what is a complex set of year ends, I think just probably needs raising here. And I know, Patricia, you came to our committee meeting last week, and I think you too were impressed by just the quality of input from the finance team. So I think it's probably just worth raising here that actually we have another support team, an admin team, who are also putting in huge efforts at the moment, and producing well, I mean, I'd classify it as one of the cleanest set of accounts that I've seen in my sort of time in the NHS. So I would just like to record that, please.
David, thank you very much indeed. I'm really glad you made that point, because I was going to say something on that, and anyone who reads the HSJ will know that a really clean set of accounts produced as smoothly as this has, as both of these have been, is not universally the case. Any other questions or comments? Right. Just on that, in that case, can we absolutely, as a board, record our thanks, Stephen, to you and through you to all your team? I mean, I was really impressed by those of your team whom I saw at the Audit and Risk Committee recently, but really, really good work on this. And I think it's also appropriate to record our thanks to our external auditors. Not, you know, giving us a report without qualifications is good. That's a reflection of our work. I'm not thanking them for being nice to us. I'm thanking them for doing a good professional job. So if we can all accept that, and obviously for people watching both reports, and the external auditors' reports are all available on our website. So we now come to, you know, in a sense, our main, the main topics that we consider as a board, very much about our service provision and how we meet and try and improve the ways we meet the needs of our residents. And we're going to start with the really important issue of how we, the really important but also very emotive issue of how we learn from the deaths of people with learning disabilities and autism. And as you will have seen from the papers, a group of people for whom health outcomes are, I'm afraid, very, very poor, often very poor and much worse than the population as a whole. So I'm going to ask Andrew O'Connell to introduce this paper. Obviously, everybody's read it. You don't have to take us all the way through it, but highlight the key points. And if you would, Andrew, just start by introducing yourself and your role within Tricia's team as Director of Nursing.
Yeah, hi. Hi, and thanks for having me today. It's really great to speak to you. Yeah, so my name's Andy. I'm a paediatric nurse by background, and I work with the learning interaction team, the leader team for mortality review for people with a learning disability and autism. And my role is essentially to lead the team. I have a great team of reviewers, and Tracy mentioned earlier about administrators. I would be absolutely lost without mine. So, you know, we have a really amazing team that's delivering sort of this service for Norfolk and Waveney. And as I say, the report that you've kindly all read, and I've had some amazing emails the last couple of days showing how well that report's been read by board members, which I really, really do appreciate. So thank you for that. But yeah, so we have a report which I'm looking to present to you today. And as sort of Patricia mentioned, some of it is quite difficult reading, and some of the key data, which I'm sure you've all seen, does show that people with a learning disability are at a significant disadvantage compared to the general population, which includes dying on average over 20 years younger than the general population. Nearly 50% of deaths are classified as avoidable, compared to 22% for the general population. One in 6 people will die prematurely when they have a learning disability. So all of these factors build into how the care and service we deliver as a region directly impacts on health outcomes. And there's lots of data in the report which you've read, I'm sure, and that's been enabled by new data collection processes this year. LEADER has completely transformed in the ICB in the way that we deliver it and the information that we collect and the learning that we can gather, which allows us a really rich view of the experience of people with a learning disability and autism, which I hope has come through in this year's report. And it's given us new ways to look at the services that we offer. So, for example, this year we've been able to look at the indices of multiple deprivation, where we're supporting residential services for people with a learning disability and autism, and actually they're disproportionately found in areas of high deprivation, unfortunately, which is something that we just weren't aware of before. So how we're using the reviews to really learn from has changed. And in regards to learning themes, we're very privileged in that we get to share in the stories and the experiences of the reviews that we conduct. But the biggest part of our role is the learning into action, and it's the learning themes. And generally, what we find is access to specialist equipment is a problem. Sort of poor documentation in the use of the Mental Capacity Act. There's a lack of preventative healthcare in regards to screening, especially screening programs for women. So cervical and breast screening. Pneumonia vaccines is a real area for us to work on this year, looking at especially as pneumonia is the most prevalent cause of death for people with a learning disability. So we've really been able to this year pull out sort of key areas of learning, because that's what directly takes us into the action. That is how we guide our project work, how we engage with the wider system, community, acute, the voluntary sector, to make improvements and to improve our access. Generally, we are on par with the country from a data point of view. We don't really have any outliers in regards to the age at which people are dying, or avoidable deaths. And pneumonia again is systematic across England. So Norfolk and Waveney is very much on par with the rest of the region. And the country. Where we do excel is our performance from a review completion point of view. We are leading in the region and also nationally, although I haven't been given those figures by NHS England, I've been told. So the team does really well at making sure that the reviews are timely, that they're of good quality, and actually that review's coming through really quickly. What we try and avoid is, although we have 6 months to complete a review, actually by then that learning could be out of date. So we want to make sure that they're rich, the reviews are rich, but we're also moving that learning through, because we don't want to be in a situation where we've got poor care going on, which we haven't been able to address because the review's taken so long. So the team works really hard, and I'm really proud of them. And learning into action work over the last year, I go through some of the project work that we've been doing in the annual report, and one thing that I wanted to really pull out was, so for example, the end of life toolkit, which we've developed for residential services. This really came out of a theme that we were seeing too many people, where colleagues working in residential services wanted to support someone to die in a place of their choice. They wanted to support them to die at home, but they just didn't have the confidence to do it. We're expecting a lot for someone to look after a very complex person at the end of their life. So what we developed was a residential toolkit to guide people on where to go for the right support. Where do we go if a person has epilepsy and their seizures are becoming unmanageable? How does their annual health check build into their end of life care? And why I wanted to pull out the end of life toolkit is that I'm not sure if any of you have seen, but the HSIB recently in July this year released a report regarding end of life care, and one of its recommendations to ICBs was that we improve how we communicate service availability to colleagues throughout the system. If we don't know what's out there, if we don't know what can support, then we're not going to be making those referrals. And in delivering this toolkit, we're ahead of the game. You know, it might seem small, but you know, we're anticipating some of the problems seen nationally, and it's something that we're already working on in Norfolk and Waveney as a response to LEADER. So there's a lot of really, really great work going on. But we also have priorities for next year. You know, the prevention of respiratory illness is a big one for us, because obviously that's our primary cause of death. You know, we're going to continue the work that we're doing with annual health checks. We want to improve the use of respect documentation, and obviously what I've mentioned about screening programs. So there's lots of areas of work for us, you know, both for the ICB, but also for the wider system. And I'll leave it there because I'm really keen to sort of have any of your questions and explain anything further. I hope that was okay.
Andy, that was excellent. Thank you. And it's great to know that we have a paediatric nurse, you know, working on this. Our media can sometimes talk about managers, you know, as if managers were some kind of faceless robots or something. And actually, managers are real people with real expertise doing hugely important jobs. So thank you. Let me come to Aliona and to Hein. So Aliona first, and just introduce yourself, please.
Thank you, Patricia. Aliona Deret, one of the non-executive members on the board. Andy, you have presented this report to the Quality and Safety Committee, and we scrutinized it quite nicely, haven't we? We have commended you and your team for such a wonderful report, very detailed, with lots of information and lots of themes we can draw from it and learn. My question today is, you made a connection to the data collection and analysis, yes, that it has been improved last year. Now, how is that process being shared across the system so we can all learn from that? And so that's the first question. And the second one, how are the families are involved in shaping the improvements we need to make to prevent those deaths, please? Thank you.
So in regards to how the learning is being shared, we have a really amazing commitment within Norfolk and Waveney from sort of partner colleagues across the system. So at our Learning Interaction Group, we've got representation from social care, from a whole array of professions and services within healthcare, both acute and community. We've got really close ties with Family Voice, who support us from a parent carer point of view. And that's really how we distribute a lot of the learning, which isn't focused maybe specifically in a piece of a project work that's being undertaken. We also have our working groups, which again, we have really amazing representation from across the system with, say, for example, we have an end of life working group where, you know, we've got people of that specialty. And the idea is people are engaging in that learning and then taking it back into their own organizations. What I've also sort of put into place this year is a really extensive engagement and teaching program for the system. I keep saying I'll talk to anybody for any length of time about LEADER, but we're speaking to all different types of students at UEA, from social workers through to med students to OTs. I'm speaking to NCH&C. I'm with the council tomorrow, speaking to commissioning teams and one of their quality boards. So we're really engaging throughout the system to share both general and system learning, but also really specific pieces of things that need to be improved. And that includes best practice as well. leader, we can sometimes get churned up in all of the bad things because, you know, they're often what we need to respond to, but there's so much wonderful, great practice out there. And to your second question,
oh, sorry, yes, second question, yep.
And sorry, Aliona, just remind me, what was the second question?
Involving families in improvements.
So we have, we're really keen to engage families during the review process. So we, and something that's unusual for Norfolk and Waveney, I don't quite know why, other areas seem to be resistant, but we will often share a draft copy of our review with the family because their engagement and their experience is so vital. So they really support what they feel needs to be improved and what they need to feel learned. And as I say, we have really strong from parent carer networks like Family Voice, who are, you know, both involved in our working groups, but also in the review sign-off process. So we have really strong links with them.
Andy, thank you for that. I'm going to come to Hein and then Tricia. And I'm also, because we have Alex Stewart from Health Watch, sorry, garbling my words, with us, of course, as one of our observers. I'm going to ask whether there are any comments from Health Watch reflecting that patient and user experience. Hein.
Thank you, Patricia. I'm Hein van der Wildenberg, non-executive member, Integrated Care Board. Andy, I know you and I have had email exchanges on this excellent report. So again, my compliments to you and the team for the depth of analysis and learnings. I had a question for which I realized there may not be a straightforward answer, but I felt it important to raise and share with board members. The report clearly states the importance of annual health checks, and we've seen encouraging progress in those being held. But the simple question, seeing the summary statistic, is that there's a potential risk we keep seeing the same 70 to 75% of the 7,000 plus people on the LD register. And that's excellent news for those 70%, but that would also mean there's quite a big contingent that potentially hasn't had an annual health check for years. And the point I was trying to make, saying that would be a huge shame and a potential source of health inequality if we don't try to verify that. I know we don't hold a central database, but at practice level, that information is there. So maybe not solving it on this call, but maybe offline, happy to have a chat how we could see if there's a potential source of a group of vulnerable people who we've missed. Thank you.
Thank you, Hein. Quick comment on that, Andy?
Yeah, so the specifics of monitoring annual health checks falls a little bit outside of my scope. It falls within sort of the primary care commissioning. I do know that, you know, we really closely monitor sort of how we perform in regards to annual health checks on a quarterly basis. And for example, I remember being in discussions at the end of the year, they were saying, you know, the 25% that we didn't cover, you know, this year, we need to make sure that we're really targeting that 25% this year. So I know that it is recognized of that 25% not being missed. I can't offer any specifics just because, as I say, I don't directly oversee it. But I mean, I'm happy to take questions away if that helps. But
let's, Andy, I suggest on that one, if you would, take that offline, particularly pick it up with Ian Riley and his team. Shared care record may be part of the answer to this, and then pick it up with Hein offline as a follow-up to this meeting. Thank you. Tricia and then Debbie.
So I'll be very brief. I'm Tricia Dorsey. I'm the Executive Director of Nursing for the ICB, but also have responsibility for learning disability, autism and Downs for the board. This report, I think, is exciting in that it gives us the opportunity to think about what can we do differently? How can we really work with the community to improve the health outcomes for the learning disability and autism population? It is part of a number of different elements, though. The LD health check, Hein, which you've raised a really good question, and we will take that one away. Also, prescribing around the stomp and stamp agendas. The point I wanted to make is that since this report has been developed, we've looked very closely at the governance to ensure that we've got that opportunity to deliver and also illuminate the importance of this agenda, not only through this forum, but through the ICP as well. And what I'm very heartened about is that in our system, people are taking this very seriously and are striving to make a difference. So thank you, everyone, for receiving this report, for Andy's passion and his leadership within the team. But I think we're doing some really good work, but of course we can always do more.
Thank you, Tricia. Debbie, and
thank you. You know, very much echoing.
Sorry, Debbie, just introduce yourself, would you? I think it's,
Yeah, Debbie Bartley, Interim Exec Director for Adult Social Services for Norfolk. So wanted to, you know, echo what Trish has said and to thank Trish for her sort of work in this space, because this is an area where integration absolutely really can, you know, transform the lives of people, and, you know, a commitment to look at that. And this report, I think, gives some really important pointers as to where we should do that. I wanted to just, you know, really reflect on the reference in there to transition between children and adults. And I recognise that's in a health setting, but actually, if I think about a social care setting, that absolutely mirrors. It's such a significant issue. And it just made me think whether or not, you know, perhaps we should be thinking about transitions, you know, as a whole, not health transitions and social care transitions. It's an individual at the heart of this, and I think that would be a really welcome discussion. But, you know, a really good report, so thank you.
Thank you, Debbie. And let me at this point come to Health Watch. Alex, and welcome.
Thanks, Patricia. My name's Alex Stewart. I'm the Chief Executive of Health Watch Norfolk. We very much welcome this report and commend you for doing it. I suppose there are some observations. We would actually very much like more people with LD or autism to perhaps be involved in as the sort of programme develops. And we're very well able to help facilitate that with context that we have from work that we have very recently undertaken by going into care homes for people living with learning disabilities. I suppose the second thing that I would like to say is we are still concerned that I think, as far as I'm aware, Norfolk and Waveney is still a national outlier as far as health checks for people with learning disabilities are concerned, and we would like to see that brought back into line with sort of national figures. Trish is obviously going to disagree with me here, so I will be quite willing to be corrected, but these were the last figures that I had seen. But anything that we can do to help, we will promote this report as well, wholeheartedly. So please, thank you very much.
Great, Alex, thank you. Really helpful. And I thought your report on the care home experience of people with learning disabilities and autism was really, really good, and some salutary lessons for all of us, I think, in that. Tricia.
So last year's end of year performance was better than the year before, Alex, and was in line with national performance. This year, in quarter 1 and 2, we are slightly lower than where we need to be. So there's a recovery action plan in place, and we're working very closely with primary care to ensure that we hit our targets of quarter 3 and quarter 4. Alex, any support Health Watch can give us is always extremely warmly welcomed. So I think I'm seeing you next Thursday, so perhaps we could catch up then to talk about the support that could be provided.
No problem. And I will say mea culpa, mea maxima culpa for my incorrect figures.
Right, no Latin here. I'm trying to get NHS acronyms and jargon translated into English, so let's not head into another language, please. Andy, I was going to come to you for a final word.
Yeah, no, it was just to say that offer of some support with networking for people with a lived experience would be amazing. Although we have really good parent carer representation at some of our groups, we have struggled to find, that source of experience and support. We work really closely with Opening Doors, but unfortunately, we just haven't been able to find anybody to sit on our groups that has A, the capacity, B, the will, and obviously the subject material is quite difficult and how we support that. So if you have any areas of support to enable that, I'd love it.
If I may
Good.
very quickly
Okay.
come back, Patricia,
Very
we
quick.
have very close links with Out and About in Cromer, and they will, I think, happily work with us and yourselves in order to help promote this agenda.
Good. Thank you very much indeed. I thought that was a really rich and interesting discussion. And Andy, thank you especially for all the work you're doing in this area and your leadership on this and the way you presented and responded to questions today. Really, really helpful. So is the board happy to receive and approve the Leader Annual Report? Thank you. And we now come to, very much in, if you like, in the same sort of territory, the work that Frankie Swords, our medical director, has been leading on learning from deaths more widely across the system. So, Frankie, over to you again. Board members have read the report, but please introduce and highlight the key points from it.
Thank you very much, Patricia. So I'm Frankie Swords. I'm the medical director for Norfolk and Waveney ICB. I won't go through the report line by line, of course, but just to give you a little bit of context, every death occurring in a hospital is already reviewed by an independent medical examiner before the death certification can be issued. And that process identifies specific deaths where there might be learning for those involved in their care. And that whole process is led by the individual hospital. From next April, every death across our community will also be subject to this process. Furthermore, specific deaths are already subject to a much more detailed review. So Andy's been telling us about the whole leader process we have to learn from the lives and deaths of people with learning disabilities. But other deaths will be looked into in much more detail, for example, if they're being investigated by the coroner. And then finally, as well as these individual bits of scrutiny, there are statistical means to look at the rates of deaths, how many people die compared to how many you would expect to die. And again, each hospital has a duty to look at and report on and learn from these. But as a system, we wanted to join up this learning and to extend it across our entire community, not just those occurring in our acute hospitals. So that is what prompted myself and Stuart Lines, our Acting Director of Public Health for Norfolk County Council, who is on the call today, although he's not actually a member of the board. We decided to set up a Learning from Deaths forum for our system, and that started in February. So this forum looks for opportunities to share and really use this learning to improve the care that we provide for our population and to tackle and reduce inequalities. We've met 4 times now, that the forum meets bi-monthly. And so we wanted to present this to the board, really to ensure that you're aware of the work we're doing. And I've also outlined some key findings of various of the deep dives we've had so far, such as palliative care, again, an area that Andy was talking about earlier, that recognition and support for people who are recognised to be approaching the end of their life. We've looked at drug and alcohol related deaths. We've looked at suicides, various different specifics where we're certain there can be learning and we can do more to improve the care of people to prevent deaths, and how we're using that information to improve our services for the future. And I've also just given a brief overview of the annual work programme and what subjects we will be looking at in future months. So I'm very happy to take questions. I'm very happy to give a bit more detail of some of the learning we've taken. But for now, that was, I think, hopefully gives you a context of the work we're doing.
Yeah, Frankie, thank you. I think that was really helpful. And I must say in the paper, that sense of both looking at individual cases and individual experiences, some of them in very considerable depth, but also looking at the data and what robust statistical analysis can tell us. That combination feels to me hugely important. So questions, in fact, even before we come to that, because I'm not seeing hands up, let me just ask Stuart Lines, you're here, as Frankie said, Interim Director of Public Health. Is there anything you'd like to add at this point?
I think Frankie's covered it actually, but really just to emphasise that we do have existing panels such as the Child Death Overview Panel.
Yes.
And I think that provides a really good model, because what we're doing is trying to prevent these awful situations occurring wherever possible, and looking at trends. That clearly is an important factor, and understanding where we can intervene. So this essentially replicates that, but broadens it out, looking for themes and opportunities for intervention earlier on.
Good. And working together so that it's
Absolutely.
not parallel processes. Yeah. Let's come to Kathy and then to Aliona.
Thank you. Frankie, you mentioned in the report about the suicide prevention and the fact that since public health interventions, it's gone down significantly, because it was rising until 2016. I think that's what it said. Do you know what the kind of major interventions have been to prevent the suicide?
So the I've reported that they happened at the same time. I don't think that necessarily means that we can take absolute credit, but the suicide prevention strategy, which was developed by Norfolk County Council, was published in then, and it just so happens that since then we have seen a reduction. I can't promise that A led to B, but they certainly happened at the same time. So that work really identifies most at-risk people. So, for example, although it perhaps will come as a surprise that the highest number of suicides in Norfolk and Waveney tend to be in middle-aged men. They tend to be in people who are single. They tend to be in people who are not currently employed. So there's some really, really rich data there, not necessarily what you would assume from reading the papers. I don't know, Stuart, if you're able to draw out any of the key aspect of what you think has really made the difference or whether it is the strategy that's made the difference.
Yes, I know. I think obviously we've had the COVID effect as an impact on mental well-being overall generally. I think there have been some various interventions that may have helped the situation, but the suicide prevention strategy does bring this together into a whole, and thinking about particular risk factors, which Frank has just mentioned, and again opportunities for intervention where they seem to be effective.
Okay, all right. Thank you.
Thank you, Aliona.
Thank you. Frankie, very informative report. Thank you so much. Couple of questions, please. When you talk in your report about the unmet need for young males from deprived areas who have cancer, what is the current approach to involving people with that experience and actually the design and improvement of services, if there is any work? And the second one, the next point regarding the drug and alcohol and serious mental health mortality, are you linking the work on the serious mental health issues with the current work done by HealthWatch? Alex can tell us more about it, but there is a 3-year program, I think, undertaken by HealthWatch in this area. So I'm just wondering what the connections are currently. Thank you.
Okay, so taking your first question, so this is in relation to palliative care services. So many of us, palliative care is very close to many of our hearts, and I was absolutely heartened to see that the work we've done in recent years has shown that where in the past more people were dying in hospital in Norfolk and Waveney than the rest of the country, actually the place of death is now in line with England averages. And furthermore, that in the past, and anecdotally to this day, there is a real perception that people who are close to the end of their life have unmet need, and they're having repeated hospital admissions in that last 6 months to a year before they die. Actually, we've seen that fall dramatically by improving recognition of patients who are nearing end of life, much earlier recognition, much earlier involvement in the planning. In terms of what we are doing about it, we have a palliative care program board, which is really focusing on how we commission and organise our palliative care, because we have pockets of excellence. But unfortunately, I'll give you a slightly depressing example. The nearer you live to a hospice, the more likely you are to get hospice care. So if you happen to live further away, or if you happen to live in an area of deprivation, you're less likely to get it. And again, we're generally better at planning hospice and proactive palliative care for people with cancer and people who are older. We're much less good at focusing it at younger people. So that's what that program board aims to do. And I'm going to have to check and get back to you in terms of the user involvement in that board. I will find out, and I will get an answer for you in terms of that planning ahead, because if we don't, perhaps we should have some people who are directly affected involved. And then the second question was about the drug and alcohol and people living with SMI deaths as well, wasn't it? So again, there's some heartening statistics in this. We were previously an outlier. We were having more excess deaths in these groups than other areas. We are now in line with the rest of the country, which is good, but there's still 1,765 people in the last year who have died prematurely because of this. So yeah, absolutely, this is a huge contributor to the mortality gap in areas of higher deprivation. And in terms of tying it together with the Health Watch, again, I think I'd have to check, unless Alex, you can help me out of
Well, no, hang on. I think I'm just conscious of time here. Can I suggest you take that offline? But what you might want to do, Karen can advise offline, but we'll either perhaps append something to the minutes when we publish those, or whatever, just so that the fruit of this discussion will go into the public domain as well. What I want to do is take David and Tricia, and then Frankie, I'll come back to you for any final comments.
Thanks. This is a hugely rich source of information, Frankie, and I suppose what I'm really interested in is how we now measure our success in dealing with some of these elements, because we've had a number of reports come to us as a board over the previous or over our first year of life, and I'm really keen that we grasp what is really open, rich reporting, but now see what the outcomes are and where the tensions may lie and where some of the pressures may lie. So I throw that in, not necessarily for an answer now, but I think as a board member, it's an expectation one has that when you see something like this, your next question is the so what question, or where are you struggling? Where are we making progress? What input do you need from the board to make this work?
Great. Thank you, David. Tricia.
So in a very similar vein, first off, can I commend Frankie for leading this group, because I think it's so important that it's in operation. And as an ICB, as an ICS, I think this really gives us the helicopter view.
Yes.
Because people do not sit in isolated buckets of care. They traverse our whole system. And this gives us the opportunity to think about the so what, David, but also to push the button if there's particular areas that are rising risks that we need to do something differently to support people. So thank you for the report, and thank you for making this happen.
Absolutely. I think all of us would endorse that, Tricia. Thank you very much indeed. And Frankie, before I come to you, I just wanted to say that a lot of this discussion, I think, relates to the much broader process of transforming, improving and transforming support and services related to mental health and well-being across the whole system, as well as within NSFT specifically. And I think, I'm not sure if it's already on the forward plan, but I think we should ensure that not too many meetings away, we come back to looking at how we are transforming support for mental health and well-being, and the community support that can be offered in a proactive way to those either individuals whom we already know are at risk, or, as you're rightly saying, wider groups, particularly those middle-aged men in certain circumstances who are particularly at risk of possibly a serious mental illness, but certainly of premature death, and including the substance abuse issues and alcohol misuse and so on in that integrated look. So I think it'd be really helpful as a board if we could come back to that, please, because obviously there've been all kinds of discussions in relation to NSFT specifically. And the other point, which is a much broader one, I think we know from other industries, aviation being the classic example, that when it comes to to improving safety, and in this case, to reducing preventable and premature deaths, avoidable deaths, then this is very much about the whole culture, the quality culture and the focus on quality, as well as learning from, when things go absolutely wrong. And in that wider context, it's not just the fatalities, the deaths that are important to learn from, it's the near misses, the precursors in, transport safety jargon. So at some point, maybe even now, it'd be very interesting to know whether your Learning from Deaths Forum is looking more widely at that and whether that could be a theme of our work across the system.
Thank you, Patricia. So you've covered a few things there, but with respect to your last point, that really feeds into the Patient Safety Incident Review Framework, the PSIRF, which has just been implemented across the whole of the NHS. So when you're talking about that culture, it's a culture of candour and it's a culture of learning, that we're really, really trying to make sure that we are open and always open to learning and sharing. A couple of other points. Firstly, of course, this forum is just one part of our quality work, and this forum reports into our system quality surveillance group and into our quality and safety committee that Aliona chairs. And finally, that we do, of course, use this learning to inform our commissioning. Whether I'm able to show direct drops and direct arrows that I think David would really like us to see, possibly not, but we do use this learning specifically to say, right, palliative care, we need to change the way that's provided. Actually, people with learning disability and autism, just like people living with severe mental illness, need to get their health checks because there are preventable deaths happening there. So that's exactly how we use it.
Yeah. Great. Thank you very much indeed, Frankie, and thank you for the work you and your team and colleagues are doing on this. It really could not be more important. So that brings us, double check. Yep, I thought so, to the winter plan. Another hugely important and extremely urgent piece of work. So I'll hand over to Mark to introduce this, please.
Thank you, Patricia, and good afternoon, everyone. I'm Mark Burgess. I'm the Director of Patients and Communities for the ICB, and urgent emergency care is a very important part of my portfolio and oversight of that. So they say you should never start with an apology, but I feel I must. We are required to seek approval from board for the submission of our winter plan, winter narrative, and this year we've been supplied with templates which you have been shared with you. Excel never translates well, particularly large Excel files, to Word documents, so I do apologise for that. But it's brought here today, firstly to seek approval of our submission, which is due at the end of this week, and also to give board members an opportunity to see the emerging themes relating to capacity and our aim of increasing capacity this winter, to note some of the planned mitigations we have in place as well. We are I'm really encouraged that I don't think I've ever brought a winter plan to board before in September. Often the guidance is much later in the year, so I consider this a very positive thing that we're having this conversation in September rather than November, December, as we have sometimes done before. So an awful lot of information in that return, but if I can try and summarise it very concisely. Helpfully, the guidance this year across the UEC recovery plan, the winter letters we've received from NHS England, being a part of the a tier 1 system as part of our recovery, there are really 3 areas that we've been asked to focus on. One is our category 2 ambulance response times, and that's for those people with chest pain, suspected stroke and things of that nature. Our emergency department performance, targeting improvements there. That's one area that we benchmark quite well nationally. And the third area is around ambulance handover response times, which we've talked about and I've talked about here many times before, which we have a long distance to travel in terms of the improvement. We are seeing some positive signs, but that is a key area of focus for us. So our response in terms of that request of us as a system, we are absolutely prioritising this winter. Number one, patient safety will always be our number one priority, working with Tricia and Frankie and her team and colleagues across the system. That has to be our number one priority this year. But linked to that, much of what you've read in that document identifies the things that we are looking to put in place to try and improve our category 2 ambulance response times, and linked to that ambulance handover, because the two are intrinsically linked. Virtual ward, which we've had updates on before, expanding our capacity there, supporting people at home, both in terms of a step up, so those people who we're trying to avoid having to go to hospital, going to a virtual ward bed, and also those coming from hospital on discharge to a virtual ward. So we've had very, very positive feedback from patients around that service, so that's one area that we're working very hard to increase. And finally, about reducing length of stay. So length of stay in both our acute hospital and community capacity, and really achieving that 92% occupancy figure. And we're looking at every opportunity, and we continue to try and get additional resources in place, funding to increase capacity where possible, to support discharge and flow across the system. So in terms of process, in terms of generation of this plan, we've worked with partners right across the system. This wasn't just ICB colleagues generating this plan. We've worked across all partners from health and care in the generation of this plan in Norfolk and Suffolk, a real coordinated approach here. The plan that has been shared, we have had feedback from NHS England earlier this week, and I'm pleased to report that we were asked to tweak areas and perhaps prioritise one or two areas rather than make substantial or whole-scale change. So I hope this is useful. I do seek approval for submission. The final point that I'd just like to make is one of our challenges as a system. We have a vast number of plans. For example, primary care capacity, access recovery, ambulance handover plans, better care plans, discharge improvement plans, workforce plans. They all come together. What is most important, I would suggest, is the delivery of those plans. So that is what we will be focusing on this winter. But I hope that's a helpful summary of where we are. But of course, very happy to take questions. Thank you.
That's very helpful indeed, Mark. Thank you very much. Right, let's come to Aliona, and then Hein, and then Stuart.
Thanks so much, Patricia. What a plan, Mark. Lots of interesting reading and very encouraging. You'll not be surprised with my question. At the last Patients and Community, not yesterday, one before, we discussed discharge. And one of the questions I asked is, how is the voluntary sector supporting the discharge program? Now, I will extend that question now to the prevention of admission. So you just mentioned that health and care sectors were involved in putting the plan together. Can you reassure us that the voluntary sector was involved, and what is the extent of that involvement, please? There's lots of resources in the sector who are able to support the program, I'm sure. Thank you.
Aliona, thank you. And Mark, just hold that question, would you? Because I want to bring Emma in, and apologies to Emma because I didn't spot the hand quickly enough. And then what we'll do, let's take Emma and then Stuart, then I'll come to Mark, and then we'll take another round with Debbie and Hein. So Emma.
Thank you, Patricia. Emma Ratzer, Chair of the VCSE Assembly. So just to answer your question, Aliona, quite a lot of the current VCSE providers have been around that urgent and emergency care and discharge table for quite a long time, and have been really involved in putting those plans together. And there's been a really good opportunity to feedback on the things that haven't worked, because those are the things that we all know about. So there's been plenty of opportunity for us to feedback to Mark and his team about the things that haven't worked and the things that don't work for the sector, as well as the things that don't work for the individual patient. So there's been lots of conversation around that. And really, I just wanted to say thanks to Mark, because this is the first time our sector has been involved in a winter plan in September, because usually we get the call in December saying, how are you going to help? And that really helps us plan, which is really important. And it has given us the opportunity to give that really important feedback before something is started, rather than halfway through or at the end, when actually what we do is come to you and tell you why it didn't work. So I would say there's been lots of conversation, Aliona. Really happy to talk to you offline about individuals and individual communications that we've had, and just thanks to Mark and his team, because it's really felt like we've been part of a process this time.
Emma, thank you for that. That's really encouraging to hear, and I hope that dialogue, I'm sure it will, but will continue all the way through the winter, so that instead of learning after the event, we're learning and course correcting more or less in real time, you know, where that's needed. Stuart.
Thank you, Chair. And again, yes, well done for getting this together.
Stuart, apologies. Have you introduced yourself? I'm losing track.
My apologies. No, Stuart Keeble, Director of Public Health for Suffolk. Thank you, Chair. Sorry, completely forgot. So no, well done on getting this together. As you say, it's great to see these far further ahead than what we used to be able to see them. I suppose recognising the pressures we're going to be under and what needs to be done, I suppose the one bit for me about these plans are it kind of loses sight of the patient sometimes, I think. And I appreciate that's a template and that's what you're being driven down to. But I think for me is always trying to go back to what we're trying to achieve for our residents. And I think actually if we do that, it will actually deliver the outcomes in the longer term, what you need to achieve. So that's just one comment. And then I think the second thing is it's great that we're looking at that in September. What does that mean? Because winter comes around every year and we know we see the seasonal variation. So I think the second point is about how do we start to, this is around flow, about getting people in and out of hospital, but what does that mean more broadly when we go forward? I appreciate it's one winter at a time, but I've been in these a number of years now, and I think it's just trying to think about what that means in practice. So how do we start to look 2, 3, 4 years ahead and build a programme around that?
Mark, any comment at this point, and then we'll take another round.
Thank you. Yes, very quickly. So first, in addition to what Emma said, and thank you for the comments, Aliona, our system simply wouldn't work over winter if we didn't have that input from the voluntary VCSE sector. So it really is a key component. And actually, it was mentioned by Emma as well, the learning is critical. We've got the learning from previous years, so it's really important that we embed that. And these plans change as we go through the months as well. So, you know, often there is additional funding. We're told there's no funding, but if sometimes funding comes in and we have plans in place ready to kind of roll those out. So that's good. Stuart, in terms of I completely agree around the risk of losing sight of the patient. In fact, one thing I hope that I can offer to positively is where we have had the more challenging discussions around planning and how things are going to be delivered. Actually, when we bring it back to the patient, that's what often gets us through, to break down those barriers of, no, I'm not doing that. Well, actually, let's just forget about what you're doing as an organisation, as an organisation. Let's focus on the individual. Let's focus on the patient, and that helps us get through. And the final point, I hate the phrase winter planning. I much prefer, you know, seasonal resilience. It's not a helpful cycle, but so I completely agree. And if we're heading towards there, I think, with colleagues. So hopefully we'll get there. Thank you, Stuart.
Thank you very much, Mark. Let's come to Hein, then Debbie, then Stephen.
Thanks, Mark. The system working is evident from reading through the narrative, both within NHS and Council and VCSE. You touched upon a virtual ward, and I was really struck looking at a chart how big the increase planned in capacity is in virtual ward. So my question is, could you share sort of some of the potential that materiality gives you looking at the system? Because it's not anymore in the margin, so to speak, but it really starts to count. Could you give us a sense?
Thank you, Hein. I might defer to Frankie for part of this answer, but what I'm really encouraged by, certainly from an operational sense now, virtual ward is one of the primary considerations, both in terms of from community before hospital and on discharge from hospital. So I think we're really beginning to notice the shift. In terms of our trajectory, we are on, I think we were a couple of beds ahead of our original trajectory in getting that additional capacity online. But we do, you're quite right, we have quite some way to go on that. But Frankie, you might wish us the lead to add a few more comments if that's okay.
Yes, thank you, Mark. So what we've done so far has made a significant impact, but really it's a drop in the ocean. And really until this point, it's been very much focused on allowing people to go home from hospital a little earlier. And really, that is not the main benefit of a virtual ward. The main benefit is preventing people ending up in hospital in the first place. So and that's known as a step up rather than a step down virtual ward. And so that integrated step up virtual ward for the whole of Norfolk and Waveney has had a slow and soft launch on the 18th of September in Norwich and stretching out to the west, and then with a view to stretching out across the whole. Oh, I've just spotted Stephen Coleman is of course on the call, and it's his organisation that hosts that step up virtual ward. But on our doorstep, looking at what Herts and West Essex have done, they are really the national exemplars in virtual ward and the virtual hospital. And so working with the medical director of their trust and really learning, we're adopting and adapting their pathways to really expand this. And the next areas of big focus are for frailty, for people living with heart failure, and for people living with chronic lung disease, COPD, and so on. And really, that's just life-changing. If those people can avoid a hospital bed in the first place, they get better care, they get better outcomes, less likely to have a premature mortality, less likely to be readmitted to hospital. That's really, and the patient experience so much better.
Yeah,
thank you.
That's really encouraging, Frankie. Thank you very much. Let's come to Debbie and then Stephen, and perhaps let's take both of those, and Mark, just make a note of anything to come back on.
Thank you.
Debbie.
Thanks, Patricia. So I think probably I wanted to echo that what comes through really strongly in this plan, and you know, we've lived and breathed this, our colleagues alongside Mark and alongside Suffolk, so you know, that's been great, is that actually, you know, most of the effort that needs to go into getting good flow through our acute hospitals, the actual change needs to be outside of those hospitals. And you know, the emphasis that Frankie has just talked about in terms of prevention and virtual ward is absolutely critical, and one that you know, from an adult social care perspective, we would heartily endorse. We're going to be monitoring really closely this year the outcomes for people. We know that in you know, we have a higher proportion than the national average of people, older people who are in long-term residential care, and we know that the translation of people who end up in short-term beds into long-term care is high, and that's not a good outcome for many people. So I really welcome, you know, the focus that is in here on, you know, keeping people at home as long as possible, prevention from coming into there, and if they are, then actually, you know, focus on getting those people back to as much independence as we can. And I welcome in there the measure that there is on long-term outcomes, because I think that's really important.
Great. Thank you, Debbie. Stephen.
Yeah, thanks. And I'll come at this working with Mark.
And
from
just introduce yourself, if you would. I think
Stephen Coleman, partner member for Community Mental Health, Chief Executive of NCH&C. It's really, as in my role of supporting with UEC, supporting Mark in drawing up the plan, there's kind of three things really that I just take the opportunity to point to the ICB as the plan goes through. I think to Stuart's bit, one of the approaches we've really tried to take is to keep consistent with the Improving Lives plan that we had through that consultancy work we did with Newton. I think they came up with a diagnostic. What we can't do is then deviate off that. So everything's got to be consistent too. Yeah. It gave us what are the issues. We've got to stick to whatever those issues are through whatever schemes we come up with. I think the other bit that I would just stress is we've got a lot of noise around us. So some of the interventions are really helpful, but it does mean that people get pulled. So the tier 1 intervention plus others, it means people are pulled in a lot of directions, and there's a slight danger that you have your plan and you get deviated off it a little bit because everyone's got their own view. So regional will have a view, tier 1 will have a view, and what we're trying to do, and I think encouraged to continue, is try and keep a consistency through that as well when we're having those meetings of saying, you know, one's saying this over here, another's saying that over there, and in some ways trying to act as umbrella for the rest of the system to just get on and do with what it needs to do rather than pull it off. But I think the last bit is, and there is a danger with plans, that you start feeling like we've got to change, we've got to add new, it's all got to be like different, it's all attached to money. One of the things I picked up from the tier one is there's some really, really good practice already in our system. What we're really, really bad at is sharing it. And I'll look at John, there was a lot that was mentioned about the Padgett and the way it manages some of its flow was really good. Are we sharing that, and can we get that and not do this? Well, it wasn't invented here, and we get into a bit of like a bit barrier up. That has got to be in the winter plan as well, but it's difficult to write in some of these plans because it's not around money, it's not around workforce. But I think there's a real thing. And just my last comment is, we've got a lot of people who are, I would describe it as in the stadium. Some are on the pitch. We've got an awful lot of people in the stands watching who shouldn't be on the stands, should be in the pitch helping us play and stop commentating. Get on the pitch, because there's a danger with some of this that's what they end up doing, is just as if it's somebody else's winter plan. It's like all of ours. So get out the stands and get on the pitch.
Stephen, thank you, because critical role here, the Integrated Care Board, in a sense, convenes all the NHS within Norfolk and Waveney, but it belongs to all partner organisations, every bit of the NHS, and working with social care with all our partners, as we've been describing. Tricia, quick comment if you would. I'm conscious of time. And you're on mute.
Sorry about that, Patricia. I wasn't going to put my hand up because the conversation was really rich, but Stephen made a really important point there, which is about keeping focused on our plan, committed to our plan. We may have to be fluid and change it as we go along if something new is thrown at us. But I agree with him. There are many voices within the system. We've got a committed plan now, and we need to ensure that we deliver it. And I would just like to bring to the board's attention that we saw a reduction in our discharge numbers by 1.6%. And that is as a result of the work in the acute, in our local authorities and in our community providers with the support of the voluntary sector. So those improvements are now starting to happen, but we've got to keep focused and we've got to remain committed. So I think Stephen's point is very well made.
Thank you, Tricia. And Mark, before I come to you, because this one is for you as well. We've had one question notified in advance, which I think is really quite relevant to this whole discussion about Benjamin Court. Karen, I wonder whether you or Chris, you might just want to put that question up on the, put it up as a slide share or read it out, whatever's easier.
Probably easy to put it on the screen. Thank you, Alice.
Right, so people can read that, but the closure of the reablement service at Benjamin Court in Cromer. And Mark, you're sort of answering this in two parts. If you pick this one up and then any other comments on the wider discussion.
Thank you, Chair. So we've provided a written response. So the question was broadly relating to the rehab services following discharge specifically, and Debbie will probably pick up that. Debbie and I've spoken briefly about this before, but if we can go to the next slide, please, just in terms of the process and what we do as a system, and specifically the question is around what more will we be doing in North Norfolk. We as part of our winter planning and things we have in place now, we have put in some additional capacity intermediate care beds in care homes across the central Norfolk area, and that covers North Norfolk of course as well, but very importantly the multidisciplinary teams that sit around those to support patients, and there's a bit of detail in there around that. And there was also a point in the question around our commitment to engaging with the population, particularly specifically around Benjamin Court, which we must be committed to doing that, absolutely. But Debbie, you might wish to say a bit more about the Benjamin Court specifically.
Thanks, Mark. So just to reassure really the board that actually what this will allow us to do is to refocus our highly effective reablement service You know, what we know is most people, you know, would rather be at home, and we'll be able to reach some 1,500 more people in their homes as a result of this change. And just I realise we've allowed a bit of jargon to creep in here, so I apologise for that. So when it refers to double up, that means where people need more than one person to be able to move, and sometimes that can be a real challenge to be able to support. So we've invested in that. Thank you.
Excellent, thank you. And Alice, thank you for that. I think we can take that slide down. Bill, let me come to you, and then I'll come back to Mark for just final comments on this item.
Thank you very much. Just with regard to Benjamin Court,
introduce yourself, Bill, if you wouldn't mind. Sorry,
my name is Bill Borrett, and I'm chair of the Integrated Care Partnership for Norfolk and Waveney and a partner member of this board. I have actually answered a very similar question in the County Council meeting this morning on this very topic. And I think that the thing that gets missed is that actually the service is improving. It's just a building, Benjamin Court, and it continued to be used by the NHS for something else. So nothing's being taken away. People will have access to an enhanced service. It's being delivered slightly differently, and it won't be based out of that building. So there is no reduction in service as a result of this decision.
Thank you, Bill. That's really helpful. Right, Mark, any quick final comment?
Thank you. So again, just emphasising seeking your approval to submit that plan, I would be grateful for. But mindful of communication around our winter plan is going to be really critical this year. So once approved by region, our plan is to produce some comms documentation that will be useful not just for board, not just for our organisations, but also for our population around some of the key things that we intend to do this year. So once we've got that approval and support, which I hope to get from region and national team on our plans, that is our intention to really communicate our plans going into the winter, which, let's be really clear, we do anticipate will be challenging, but we will do it together.
Excellent, thank you, Mark. Is the board happy to approve the winter plan for submission? Good, thank you all very much indeed. I think that's unanimous. And I've deliberately allowed that discussion to go on because I think it's so important to every organisation, but above all to our residents. So that brings us to a final discussion in this part of the agenda about proactive interventions. And I want to turn to Debbie first, just to introduce that, and then we'll go to Gary Heathcott.
Thank you very much, Patricia. So really welcome the opportunity to bring this to the board. So in Norfolk Adult Social Services, we've been undergoing, a piece of transformation work for the last 18 months, known as Connecting Communities. And the essence of that is to think about how we can prevent, reduce, and delay the need for social care enshrined in the Care Act. Clearly, as a department, we tend to see people once they've got quite a high level of need, but actually we want to think about how can we, intervene with people before they need a high level of need. And so this piece of work is, really at the foothills, I think, of what is possible in this space. And through the use of new technology in interrogating the information that we already have about people, being able to, target individual people with an intervention before something has happened. And I think there is huge potential, and I know there are other streams of work that resonate with this and are similar, and a real opportunity, I think, going forward. But Gary will be able to give a bit more detail.
Great. Gary, and introduce yourself if you would.
Thank you, thanks Debbie. Good afternoon, I'm Gary Heathcott, I'm Director of Commissioning Adult Social Services for Norfolk County Council, and I have some slides to share that will help us tell the story of proactive intervention.
Okay, now, Gary, we can see the slides. I'm always very keen to avoid, death by PowerPoint. So just take us through these, and it'd be really helpful if we can have them circulated after the meeting.
Of course, yeah, happy to do that. Okay, so Debbie's actually done the preamble for me, which will enable me to move on a little bit quicker. So hopefully you've now heard about connecting communities, and you knew about it anyway. The way in which Norfolk is transforming its services and its offer to the residents of Norfolk, moving away from the way it targets services. So moving away from reactive and formal support to more proactive, targeted and preventative support. And this particular theme within Connected Communities, called proactive interventions, is about identifying at-risk individuals using sophisticated data analysis, intervening to mitigate that risk, and then exploring the future use of this kind of model in Norfolk. That's what we want to do. And we decided to test this new capability with people at risk of a fall. And we've got a pilot that's happening at the moment using adult social care records, and a phase 2 which builds on that and starts to use records and information coming from South Norfolk district records, so to enhance the offer really. So I'm going to talk through just a few of these slides. So very quickly on this one, so it's a digital platform, it's a falls prevention pilot, that's where we're testing it. It needs partner collaboration, being able to share data and joining up data in a different way, and we're using software to enable us to do that. And it's about setting up this capability for the future, and can we make this a business as usual approach, not just looking at falls, looking at all different kinds of cohorts. So the way it works is extracting information from social care notes in all interventions, and matching that information to generate a holistic understanding of a person's needs, and then understanding that using natural language processing, which it manages to scan those records and make the necessary link between phrases and words within that documentation at pace, so it can cover pages and pages of notes at quite high pace, and then links those together to create a model to highlight those that we think are at risk of a certain condition, and this one was fall. And tests show the model so far is correct up to 70% of the time. So that's what's going on at the moment. To give an example of what we're doing, we've got a customer here. So at the moment we've used adult data and place, and what we're trying to do is just look it through the lens of social care data at the moment, because that's what we've got. But also we're now going to use phase 2 and look at district as well. But think about what more we could do in the future if we used health data from children's services, etc., and tech-enabled care. So there really is quite a lot of things we could do in this space. And here's an example of how it works. So using the case of Sarah, it's looking at her case notes, picking out those terms or words that link to certain conditions or positions they might be in. And if you look at this one, obviously I'm not going to read through all that, but you can pull out from that there's an issue of bereavement, maybe mobility issues, certainly falls, and possibly something around debt. So it pulls those out from that text. And on this slide, it just explains how that would work then in reality. So it's identifying the people, the cohort you want to apply this to, contacting those people, offering the intervention, and then following that up to see if it's had any effect whatsoever. And using the Sarah example along the bottom, she was identified at risk of a fall. She would receive a letter letting her know we'll be in touch. The Protect Now NHS team for phase 1 would have made contact, an initial conversation that then could lead to a more holistic telephone call about how we could help, and then a referral into a range of services that could happen at that stage, and a follow-up to see if it's had any impact whatsoever. And you can see along the middle band there the kind of things, won't run through all of those, that people could be referred into, whether it's about environmental adjustments, mobility and keeping active, social isolation, local groups, financial services, health services. So a wide range of services that people could be referred into. Output so far, so the original cohort was 2,000 people, and letters were sent out. 700 people were made contact. 538 of those 700 answered the calls and actively took part. 278 people took that to the next step and had that more holistic, in-depth conversation that takes a little bit of time to understand how we can help and the kind of support they may need. And 156 people agreed to take up that offer, and there were 239 referrals between them. So obviously some people were referred into more than one of the services I talked about on the last slide, which is encouraging. They obviously needed help in a number of ways. Now, we do recognise it's early days for us at the moment. We're doing an evaluation that will be complete in January on that phase 1, and then we'll be right into phase 2 as well. But certainly early conversations are showing that it's having some impact. And particularly here, you can see about the fear of falling, which has dropped by 15% in the people we followed up. Obviously feel better about that. And also there's lots of other benefits that we're getting from this. So we've got to do it, I think, on a larger scale, and we'll get more feedback in January, but certainly encouraging signs. If we think if this could stop falls, stop people being conveyed to hospitals, hospital admissions, coming out, going into long short-term beds, possibly then long-term care, completely life-changing positions from a fall, and which is important to all of us on this call in various roles we have.
Great.
Just one slide then, and I'll wrap up, if I may. So we're talking now about future opportunities, 2 parts of this. One, what other things could we look at for the use of this kind of technology, whether it's social isolation and loneliness, which we know is a big issue with older people, self-neglect and hoarding, expanding the falls work, lots of other ways. I'm sure people on this call, and we're talking to children's services at the moment about things they may want to do it. So there's the additional cohort angle to this, and then there's the additional partners, which one of the slides said before. At the moment, social care lens, then district council information, and think about how we could expand that further to look at health information, and then how rich this technology could then be in targeting services for those most at risk. So I'll leave it there, Patricia.
Great. Gary, thank you very much indeed. And apologies, when you first put those slides up, I thought they were new slides as distinct from the ones that are already in the board packs. So obviously we've had a chance to look at them in more detail, and they're very rich. Let's take comments or questions, Frankie, and then Emma.
Thank you, Patricia, and thank you, Gary. It's not so much a question, more just an absolutely ringing endorsement. I'm really passionate about trying to make our services easier to understand and easier to access, and yet we so often come, after the horse is bolted. It's always apparently too late, and I just think this is wonderful. I think the use of artificial intelligence essentially to really automate and use the data and the information we've already got to identify people at risk is just wonderful. And I'm really excited to see the evaluation, and then assuming the evaluation shows that it is as good as we hope it is. You're right, the real benefit comes later, because this is just people who are already known to social services. But if we can reach out and out and out, how much better it will be if we can intervene early and prevent rather than jumping afterwards. So terrific work. Thank you.
And Gary, if you would just make a note of any specific questions or things you want to come back on. I'll come back to you at the end after we've sort of gathered up several points. Emma, and then Bill, and then Hilary.
Thank you, Patricia. This might be a question for Stuart Keeble, but I'm just wondering what the connection is, please, for Waveney and Suffolk County Council, because I know on the quick wins you've got housing support. If I live in Waveney, my housing support services are funded by Suffolk County Council, and you can't access them if you're in Norfolk. So this looks like one of the services that looks really good on paper, but when actually you're a Waveney resident and you're trying to access something that's supported by Norfolk County Council or the ICB, it becomes very difficult if the interventions you want to use to support that are funded by Suffolk County Council, because they're not available in Waveney. Sorry, long question.
No, the issue around our Waveney residents and ensuring that there's proper connectivity with the Suffolk piece, we can pick up on later, particularly if Stuart wants to come in on that. Bill.
Yeah, no, thanks. Frankie, this is amazing. It's not been possible in the past because we haven't had the technology in order to identify and read the vast volumes of notes. We'd have needed thousands of people who'd have taken years to trawl through all this information. So this is the first time we've been able to do this. So this really is brand new. And, we call ourselves a health service. This is about keeping people healthy. This is about keeping them out of the arms of general practice and out of A&E and out of our ambulances and out of long-term residential care. So if we can, and this is with only a very small access to a very small amount of the information that we have as a system, and of course it's just a pilot, so we haven't rolled it out. And I think some of the issues that Emma raised, you know, we'll pick when we, if we do feel there's value in this, and we'll take it on, and these are all things that we can address, because I do know that East Suffolk Council, you know, would be very supportive of all of that as well. So you know, this is a real breakthrough, and that's why I was so keen that it come here to this forum, because I think it will make a real difference. Thanks, Patricia.
Bill, and thank you. And my apologies, I should have thanked you at the beginning for suggesting this went onto the agenda, because it also helps to make very real for all of us what digitally enabled or data enabled transformation of health and care really means in people's lives, rather than in some of the more technical jargon that you know, we can get a bit carried away with. So really, really helpful. Emma, then Hilary, then Stuart. Sorry, Emma, you've...
Yeah, no, sorry, that's a legacy, sorry.
That's a legacy hand, so sorry. Hilary, and then Stuart.
Thanks, Patricia. So I'm Hilary Byrne. I'm the primary care partner member on the ICB board. So my question really was a bit about the numbers. So I think there was mention of 2,000 letters went out, and of those 156 people actually took up an intervention. So I think that's around 8%. I just wondered whether there were other mechanisms we needed to think about as to finding people who are receptive, who are at a point in their journey where they would accept help, or whether there are other things that we need to factor in order to improve that uptake rate, because that does seem a little bit on the low side.
Thanks, Hilary. Stuart.
Just picking up on the Waveney side of things. I mean, we work closely, and Anna Crisp, who is my head of knowledge and intelligence, is working with Norfolk and Waveney on the procurement around the wider PHM work. So we do work across, but obviously would be willing to, and we do continue to keep in contact with Norfolk colleagues more broadly about the opportunities of learning from each other. I mean, there is the Waveney area in that sense has a great deal of opportunity as well as challenges around that, in the sense it has innovation coming from Norfolk and Waveney, but also the work we do with East Suffolk as well. So I think I agree, it will never be perfect, but at the same time, it's about how we work with each other and work out what we're doing. So as ever, Emma, we try to be in the conversations to try and link up where we can and make the most of it, but recognise also it is a bit messy, but we just have to, we do our best for the population, really.
Brilliant, thank you, Stuart. And I think we know that whether the integrated care boards are organised on a county footprint or what we currently have, which is more of a health economy footprint, we have to work across boundaries anyway, and doing that to make sure that the population get the best possible support is critical. Before I come back to you, Gary, can I just add a couple of questions of my own, because I think Norfolk and Waveney is becoming a real centre, and often not recognised, for some very exciting innovations. And I just wanted to ask whether, in the work that we've just heard described, that you're leading with this proactive intervention, are you looking at what feels to me like quite similar approaches, perhaps not with all the artificial intelligence stuff in there, but quite similar approaches that are coming out of primary care and using primary care data? Because there's a great, there's some really good examples from some of our primary care colleagues proactively reaching out, identifying the most vulnerable patients and reaching out to them. And clearly, if we can put primary care data into the mix with the kind of data you're accessing, then we can be even more effective. And so that was one question. And then the second question is, have you had an opportunity to look at the innovations that are going on in domiciliary social care? particularly from what I understand is now our largest single domiciliary care partner, which is a company called CERA, CERA, who are using artificial intelligence to predict people amongst their client base at risk of a fall in the next 7 days, and then proactively intervening, changing medication, whatever, and very early results, but showing significant numbers of falls avoided compared with what had been happening, a year earlier. So just those two questions, if you can add them to the to your response to the conversation.
Thank you, Patricia, and thanks for all the comments there from people on the call. And thanks for the support. Just a couple of points. Obviously, we'll take away the Waveney point and build into any evaluation and next steps. With regard to effectiveness and the number, Hillary's point, that's a really good point. We did stop halfway through that pilot and change some of the language because we recognised it was a bit, it wasn't having the effect we want. So when we talk about re-abling services, actually, if we change that into chair-based exercises or different types of language that people understand, the take-up increased. So that will be one of the reflections we have as we do the evaluations about how we communicate with people and make them see the advantages of that. So that's something we want to look at. And Patricia's point, yes, we are linked in. We are having early conversations about other types of data we could use, but really appreciate anyone on the call who can push those conversations with primary care, because we would really appreciate that. And Seracare, yes, I've met them a couple of times already, Patricia, and we're looking at, because they are our biggest provider of home care now, and one of the blocks, and no doubt will be one of our future strategic providers of the new model. So yeah, very interesting stuff they're doing in the market, and we're certainly linked into that to take advantage. Thank you.
Good. And I'd certainly urge you and Ian, as our Director of Digital and Data, take that offline and look at how the shared care record might play into this and enable an even faster development of the innovation. Tricia, I saw your hand go up. Did you want to add anything?
Just to say that we've had conversations with Sarah and they've been very proactive with regards to different technological opportunities, not only within individuals' own homes, but thinking wider perhaps into the care homes and using technology as well. So yes, I think I'd echo Gary's point, could be a very useful partner going forward. Good.
Debbie.
Thank you for indulging me again, Patricia. I guess I just wanted to be upfront about this and say, actually, this hasn't been an easy journey to go on. Actually, when we first talked about this and said, actually, you know what, we're going to use all the case notes, we're going to run some stuff over them, and then we're just going to identify some people, we're going to write to them. Our data protection and information governance people quite rightly went, whoa, wait a minute, what is all this going on? And we haven't gone into that, but it has been a significant sort of hurdle to understand and adapt and overcome, and we've learned masses from that. And then there are the whole ethics around artificial intelligence that we're beginning to get our heads around, and we've got an ethics board now in the county council. But that's part of the reason why we've narrowed this and kept this to our own data, because it was as much as we could do really to get the right processes in place around our own data. And just to remind people that adult social care is a means tested service, so we are dealing with a small proportion of the population, and actually the eligibility to get into our service is quite a high bar. So most of the people that we're dealing with have quite high needs anyway, which is also a factor in the sort of the translation of the number of calls to people, which is why we're so keen to get other data sources in there, because those are the people who we don't know about, but who are our future people. And so to get downstream, I think, would be really powerful. So really welcome the dialogue today.
Good. And any quick final point from you, Gary?
Thank you. I think the only point, and just taking on Debbie's point there, is this becomes an opportunity across lots of different cohorts with lots of different information. There's going to be a way how we communicate this to the public, because some people do see AI and use of data as a threat and see it as machines making decisions about people. But this is an example all the machine bit has done is enabled us to access lots of notes very quickly that would have took months and months. The actual decision making about the care and support is about between humans, you know, but as the messaging will be really important as this kind of technology gets embedded across our system.
Great. Well, thank you. And I'm sure everybody would really endorse and just say how encouraging it is to hear about this work and the initiative you're taking and the innovation. I think it's really terrific. So thank you very much indeed for bringing that to the board. Now, I'm conscious of time here. We haven't got very long, I'm afraid, for remaining agenda items. Stephen, with apologies, over to you for the financial report.
Thank you, Chair. So this is the financial report to the end of July, which is the month 4 report. So we are currently reporting a year-to-date break-even position, which is in line with our plan, and we're currently got a break-even forecast outturn position, also in line with our plan. At the time of writing our cost improvement plan, we had a gap. We ran a close the gap event over a series of weeks. I'm pleased to say at this point in time, we've closed that gap. So we've fully identified a savings plan for the year. We've also got some other risks to mitigate within that position. So part of our plan for the year was looking at investment slippage, which we could use to support a break-even position. We've seen 4 million CHC cost pressures arise during the year, consistent with what we saw last year, and 1.5 million of prescribing cost pressure come into the position as well. The current position offsets those through non-recurrent measures. What that means is our underlying position, we started the year with an underlying deficit position of 57 million to manage. That's increased to 79.3 million as a result of those non-recurrent measures as we move into next year. Our risk position, we started with a 75 million unmitigated risk, which sat outside of our break-even plan. So our task this year has been really to manage down the level of that risk. That's currently at 43 million. And as we've worked through the financial year, we continue to reduce that risk down either by risks not crystallising or finding mitigations to some of those. The ICS position, and just to be clear, this is our 5 NHS providers and the ICB position. We are showing a 20.3 million deficit at month 4, which is 9.5 million adverse to our plan. We do still have a forecast outturn of a break even, but we've currently put the ICS system into what's called double lock, which is where any investment decision over 50,000 needs to be approved by the investment panel across the ICS. So we will continue to review that. As we get into month 6, we can start to make forecast outturn changes from month 6. So we've committed to reviewing that as a result of going into double lock. Breakdown of those positions, the Norfolk and Norwich has a 4.6 million deficit position, which is due to industrial action particularly. Queen Elizabeth Hospital has a 3.8 million gap, mainly through to slippage on its savings programme, also industrial action and RAC related issues. The James Paget has a 1.1 million variance to plan adverse. Again, similar issues, industrial action costs and cost improvement plans not keeping pace with the original phasing. Our capital position, we're currently behind on our plan by 5.9 million. That's mainly due to changes in phasing of some projects, and we expect that to catch up by the end of the year. And we're reporting at the moment we will fully spend our capital allocation for the current financial year. Conscious of time, so I'll hold there and take any questions on the finance report.
Thank you very much, Stephen. Any questions to Stephen? I know our colleagues on the Finance Committee have been discussing this in considerable detail. Stephen, thank you very much indeed for that. I think as a board at this point we can simply accept and note that report. So that brings us to the board assurance framework. Karen.
Thank you, Chair. I'll keep the report brief. The changes to the board's assurance framework this month are cited in the paperwork, so you can read through that. Really happy to take questions on any of those. Just one point, there has been a bit of an update to BAF 21 since we published the papers last week. I was just going to hand to the risk owner for that item, Frankie Swords, who could just update us. I don't have any further points though. Thank you.
Lovely. Thank you, Frankie.
Thank you, Patricia, Karen. So as was presented at the last board meeting, the Grant Thornton review looked at the collection, processing, reporting of data around deaths at NSFT. Since that meeting, we've recognised the risk that if we fail to learn from the tragic events reported in that review, we might miss opportunities to prevent future deaths. NSFT had already started to formulate their action plan, and at the time of that this BAF risk went to our quality committee, that was the state of play. But as a result of the discussions from last time and further discussions at the Norfolk and Suffolk Health Oversight Scrutiny Committees, I just wanted to update that things have moved on. So rather than a plan being developed and enacted in isolation, which was never the intention, we've now got a task and finish group to oversee co-production of an appropriate action plan with both Norfolk and Waveney ICB, but also Suffolk and North East Essex, and the authors of the Forever Gone report, Health Watch and NSFT. So I just wanted to ensure that people knew that actually things had moved on since the risk was submitted.
Good. Thank you very much indeed for that, Frankie. Any questions or comments? No, that's fine. So again, I think we can accept and note the updated board assurance framework. And we will now take a very quick highlights from our committees, starting with Aliona and the Quality and Safety Committee.
Thank you. We had 2 meetings, and of course, a report was circulated, but I'm going to pick up on 2 items. Ambulance and urgent and emergency care resilience. Mark in his report talked about the national plans to subdivide the category 2 patients. East of England Ambulance Service confirmed that they are going to begin this work at the end of September. So we are implementing that division locally. And the second one, I'm highlighting because we have agreed as committee to open a new committee risk is around the area on the prevention of liberty safeguards assessments, which currently there is a big waiting list and waiting time for those assessments to take place. So we have asked for information, what is causing, what we can do, and also identify that as a risk on our committee register. Thank you.
Thank you very much, Aliona. Any questions on that? No, that's fine. Let's come to Hein, Finance Committee. Anything to add there?
Patricia, I'll take the paper as read, and Stephen has kindly covered month 4 results, so I think he's covered the main points. Happy to take any questions.
Thank you. Any questions to Hein? No, thank you. Debbie, Primary Care Commissioning Committee. Anything to add?
Just to highlight really the issues we wanted to sort of put in front of the board. They sort of had an echo and resonance today, so around the resilience of primary care, resilience of dental services, and you know, interestingly, the learning disability health check. So would encourage board members just to take a look at those, but otherwise nothing to add. Thank you.
Fine, thank you. Any questions or comments to Debbie? Fine. Hilary, anything on the Performance Committee?
No, thank you. I'm really conscious of time. No, hopefully you've all had a chance to have a look at the report. Obviously, the impact of strikes has been quite significant on elective recovery. There's some issues around diagnostics and staffing, so not just waiting for diagnostics, but also waiting for reports. But I think everything else really is quite self-explanatory, hopefully, so happy to take any questions if anybody has any.
Thanks, Hilary. Any questions or comments to Hilary? Fine, thank you. Aliona, on patients and communities.
Thank you. The 2 areas, children and young people and maternity services, we had a very robust update on the work to date. We have asked for examples of the difference all the current programs are making, including feedback from residents who are receiving those services. So just to congratulate that team, lots of work is happening. We just want to hear from our residents now. Discharge transformation program also, we looked in depth as to what is happening, and you heard some from Mark already today that there are plans in place to make sure that we address this issue. So thank you so much. Any questions on that?
Great. Any questions to Aliona? Fine, thank you for that. David, I think because of the timing of audit and risk, we can take this at the next meeting when we have a written report. Is that okay? Good. Kathy, anything to add on remuneration and culture, and people and culture committee? I think you're still muted.
Sorry, we've obviously been talking about the internal restructuring and you know, the consultation process, so nothing to add there.
Fine, thank you very much. Gosh, 1 minute to go. And the question we had in advance from a member of the public, we've already taken. Other questions that were submitted late will, of course, be answered, as I said at the beginning, and the answers will not only be sent to the person asking the question, but put on the website. Is there any other business? No, thank you very much. The date, time and venue of the next meeting is on the agenda, Tuesday the 28th of November, and we'll be meeting in person in Cromer, I'm delighted to say. I've just spotted Richard Chilvers, one of our guests or observers. Richard, did you want to?
Yeah, I just wanted a couple of questions. I don't know if there's anybody else from the public, but yeah, there's a number of questions. I haven't been able to attend some of these meetings for the last year or two, really, to be honest, since I think changes have taken place to the CCG. There was just a number of questions. I weren't too clear about Benjamin Court. Is this a failure of the private provider, which the NHS was using, firstly? I'm not too need to be clarification on Benjamin Court. Is it a private care home that's collapsed, or for one reason or another? I'm not too sure about that. I'd just like to support what Frankie Swords was saying in terms of the importance of step up rather than step down. Seems a bit more creative about virtual wards if actually trying to help people rather than actually discharge people from hospital. And in particular, her comment that in fact the lack of hospice in the whole of Norfolk and Waveney area, so that basically if there's a hospice area close to people, they're more likely to survive or at least looked after better in terms of that. Another question I had for the finance, because I haven't been on before, you say 30% cuts. Now, how do you define that in terms of operational?
Richard, my apologies. I'm really sorry. I am going to just stop this because
you're going to stop me, are you, Patricia?
Richard, what I just wanted to say was you've clearly got a lot of really interesting and important questions. We have come to the end of the meeting.
I know you have, but there's supposed to be a public questions area.
What I would like to do, Richard, because we do ask for questions, you know, in advance so that we can actually make sure you have a chance to ask the question and get an answer at the point where we're discussing it on the agenda. What I would like to do is just make sure that one of our team is in touch with you so that we can actually answer questions you've got, but also make sure that perhaps at our next meeting in public, you can actually get the questions in advance so that we can come to you at the right point in the agenda, rather than try and pick up half a dozen different things right at the end of the meeting. So my apologies for that, but could you please, hopefully one of our team already has your email address or contact details, but if not, could you please make sure that you give them to us via our
Patricia, there is a major paper which is being sent to you from Lowestoft and Waveney anyway about various issues through the Lowestoft Hospital site. So your documents will be coming through to you about that. Really.
Great.
All right. Thank you very much.
Thank you very much indeed, Richard, and we'll look forward to a proper conversation with you on another occasion.
Right,
thank you all. Thank you all very much indeed. This meeting is now concluded. For board members, Bill. Okay, can I just say we will take a 10-minute break before the meeting of the board in private to consider part 2 of our agenda. So we will resume as a board for the in-private meeting. We'll make that at 4:15. All right. Thank you all very much indeed. And thank you particularly to members of the public and colleagues for joining us today.